Scapular fractures. Published by WordPress.com. Page 1, Scapula fractures. Page 2, Scapulothoracic dissociation. Page 3, intrathoracic dislocation of scapula and flail chest. Scapula fractures. Rare but dangerous. Polytraumatized, chest compromised. Classification. 1. Anatomic. Type 1. Scapular body fractures. Type 2. Apophyseal fractures, acromion and coracoid. Type 3. Fractures of the superolateral angle, scapular neck and glenoid. 2. Intra-articular glenoid fractures, Iberg classification, AISM. Type 1. Avulsion fracture of the anterior margin. Type 2. Transverse fracture through the glenoid fossa exiting inferiorly. Type 3. Oblique fracture exiting superiorly, often associated with acromioclavicular joint injury. Type 4. Transverse fracture exiting through the medial border of the scapula. Type 5. Combination of Type 2 and Type 4 patterns. Type 6. Severe comminution of the glenoid surface. 3. Acromial fractures, Kuhn et al. Non-displaced or minimally displaced. Displaced but not compromising the subacromial space. Displaced and compromising the subacromial space. 4. Coracoid fractures, Ayers and Brooks classification, anatomic. Type 1. Coracoid tip or epiphyseal fracture. Type 2. Mid-process fracture. Type 3. Basal fracture. Type 4. Involvement of the superior body of the scapula. Type 5. Extension into the glenoid fossa. Suffix A or B denotes presence or absence of damage to the clavicle or its ligamentous connection. And 5. Coracoid fractures, Agawa et al. Classification, functional. Type 1. Proximal to the coracoclavicular ligament. Unstable. Type 2. Distal to the coracoclavicular ligament. Stable. Clinical presentation. Symptoms: pain, swelling, and deformity over the scapular region. Signs: Campoli sign, triangular swelling overlying the scapula compartment. Associated injuries: rib fractures, clavicle fractures, pulmonary contusions, or spine injuries. Imaging. 1. X-rays. True AP view, scapular Y view, axillary view, for acromial and glenoid rim evaluation. 45 degrees cephalad view, for coracoid fractures. 2. CT scan. Useful for detailed visualization of fracture displacement and comminution. Management. 1. Conservative treatment. Indications: majority of scapular fractures. Methods: sling immobilization for 2 weeks. Early range of motion, ROM, exercises after immobilization. 2. Operative treatment. Indications: displaced intra-articular glenoid fractures, greater than 2 step off and involving greater than 25% of the articular surface. Scapular neck fractures with greater than 40 degrees angulation or greater than 1 cm translation. Floating shoulder, scapular neck fractures with displaced clavicle fractures. Acromial fractures impinging on the subacromial space. Coracoid fractures resulting in coracoclavicular separation. Comminuted fractures of the scapular spine. Methods: Judet approach for surgical access. Fixation with screws, tension band wiring, or mini plates. Complications: malunion, misaligned healing of the scapular fracture. Suprascapular nerve injury. Risk of nerve damage due to proximity to fracture or surgical intervention.